Welcome everybody to Spine Time, your free webinar on back and neck pain with the Weill Cornell Center for Comprehensive Spine Care experts. Today we have a very exciting talk, probably something that comes up quite a bit, and I am very excited to be able to share the screen with two of my close colleagues here. We're going to be speaking about neurosurgeons and orthopedic surgeons. Who does what for your back? And we should probably add neck as well to this. Just a couple of housekeeping reminders. Please keep your microphones muted, your cameras off. Please share any questions you may have through the chat. We will do our best to get through them and address them as we go through this. Our website is comprehensivespine.weillcornell.org, where you can also find information on how to make an appointment with us. And this is our every 2-week YouTube video on spine care. And we have been doing this since the start of the pandemic. You can find our old videos on spine-time.org. Again, spine-time.org. So again, the Spine Center, located on 59th and 2nd in the Upper East Side of Manhattan, is a multidisciplinary center for all things related to back and neck care. We feature surgeons, but also pain management, neurology, rehab medicine, and offer other therapies that we work collaboratively with. And the idea is that it's a one-stop shop. So I'd like to introduce our titans in the field here today. Dr. Dan Rue is an associate professor of orthopedic surgery in neurological surgery and an assistant attending and neurological surgeon at Weill Cornell. And Dr. Roger Hartle, who is a professor in neurological surgery and an attending and director of the Center for Comprehensive Spine Care. And I've been working with these two fine gentlemen for a long time, and I'm glad that we were able to talk today just to understand how does spine care go about through your different disciplines. So most importantly, we've ultimately found that a patient needs surgery. Where do they go next? And I'm gonna leave it broad and try to think about what you would advise a patient on how to pick a surgeon. And maybe we'll start with you, Dan.
Well, thanks, Neil. I think that what you got here is an excellent list. I think that for most people who are looking for a surgeon, it's actually not easy. And I can tell you that as somebody who was looking for a cardiothoracic surgeon for a friend of mine, and a friend of mine contacted me and said, I need cardiac surgery, and who would you recommend in New York City? And so I had to go on the hunt. I had to ask a lot of people. And for somebody in the medical field, it's actually pretty easy. I call up cardiologists, cardiac heads, anesthesiologists, and ask them, who would you go to if this were your family member? And then within a day or two, I can get the top 2 or 3 people. But unfortunately, the average person out there doesn't have that kind of a connection. And so it's very difficult for the average person to go out there and try to figure out who might be the best person for a given problem. Because now medicine is so subspecialized and specialized that you need to find, if you have somebody who's got a cardiac problem, it's not necessarily a cardiothoracic surgeon, you need a cardiac surgeon. And the other thing that most people, I think, in the lay public don't realize to the extent that they should, is that doctors and surgeons are like everybody else. You have great plumbers and you have terrible plumbers. You have plumbers that are in the top 5% and you have plumbers in the bottom 5%. And if you're not a plumber, you have no way of knowing if somebody is phenomenal or if somebody is not so phenomenal. And it's a bell curve. There are going to be great people in every profession and terrible people in every profession. So you have to try to sort of figure out who is somebody who's competent. Now, one of the good things about if you go to a major teaching institution, like Cornell, Columbia, Mount Sinai, HSS, NYU, et cetera, you're likely to get somebody that's at least significantly above average. But there are also great doctors in private practice, and there are not so great doctors who are in academics. So you got to try to figure out all of these things. So when you're getting down to actually selecting a surgeon, I think probably the best thing to do, if you're not a doctor yourself or in the medical field and you don't have access to talking to people in the medical field, is to ask your primary care doctor and say, can you recommend somebody? And then ask other people who've had spine surgeries if you're looking for a spine surgeon. And finally, if you have access to somebody, and I mean, they say that we're all separated by only a few degrees of freedom and a separation. And so if you contact somebody who might know somebody, word of mouth, I think, is probably the best way to get after somebody. And they could be an orthopedic surgeon, they could be a neurosurgeon, they might be a professor, they might be somebody in private practice. Now there are a couple of different things you can do. You can look at, things like U.S. News and World Report. You can see best medical doctors to get sort of an idea of who might be reasonable. But again, that's just a starting point. So that's sort of a long-winded answer to try to get at the fact that it's not so easy.
Certainly, you hit the nail on the head that it's Roger, I would ask that you take that answer too and see what your thoughts are.
Yeah. So, what I would, first of all, I agree with Dan's kind of summary of, it's a very difficult problem. And I can tell you, having family members with back issues, it's even in the spine world, for me, it's a problem to figure out, who's the best person for what. Fortunately, what we do here and what the major academic institutions do, that we do a lot of the selection already for you. So I think that you can pretty much assume that, the surgeons that we have here obviously are going to be all top surgeons. And there may be personality differences, and some patients may get along better with one surgeon or the other. But I think we try to be very transparent, and we we hire people who we know are technically excellent surgeons and are ethically also excellent surgeons. And I think that the same is probably true for most major academic institutions, certainly in New York and elsewhere as well. What I was, Dan joined us. Dan is an orthopedic spine surgeon who specializes in the cervical spine. And for me, having been at Cornell for many years, that was really a very, very important step, because, as Neil, as you know, we've been working together in the spine center, and we've got multidisciplinary or interdisciplinary approach with pain management, physiatry. And we've also we've always worked with neurological or neurosurgeons who did spine. And the question then came up, well, what about an orthopedic spine surgeon? And I think for me, that was always a very, very important component that we didn't have. And because I think there are certain aspects that orthopedic surgeons cover that we as neurological surgeons, even if we're trained in spine, maybe are not as much focused on, and vice versa. So it's really additive. And maybe we want to talk about that a little bit as well. But I think for world-class spine program, you need the input from orthopedic, from neurological spine surgery, as well as from all those other subspecialties that we have already. And plus the others that are a little bit outside, like, mindfulness and cognitive behavioral therapy and so forth. So again, the attempt is to really get everybody together to, at the end of the day, to provide the best possible spine care for our patients.
Let's
Go ahead.
I'm sorry, go ahead, Roger.
No, please go ahead.
So let's dive a little deeper in some of these points that are on this slide. If you were a patient, how valuable is it to have somebody, who's well published, or that is involved in a lot of development of new therapy, new devices? What does that lead to?
Yeah. Well, I mean, I think it's an external sign of professionalism and qualification. I think at the end of the day, it's a puzzle. You got to put it all together. And just the fact that somebody publishes a lot doesn't mean that they're going to be technically the best surgeon, or they have the best bedside manners, or they're ethically, the best person. But it's a component. It may make a difference. If you have one surgeon who is great, the other one is great, one has a lot of publications, well, maybe that's, for some people, that may be the tipping point to maybe see the other surgeon. So you got to look at, obviously, the most important thing is the technical ability, in my opinion. I think it's the personality. I think because you're trusting that person with your life, and I think there has to be some kind of personable relationship with the surgeon or with the medical team. In my opinion, it's important where they practice. You want to make sure they practice at a good hospital. There's a team approach, that the whole experience for the patient, because surgery is only one thing. Then after the surgery, you have to recover. What happens if you have a complication? So you got to make sure that you go to an institution that can cover all those aspects of surgical care. So, and then a lot of the other things are just kind of, it's like the icing on the cake, the publications, the, maybe some of the educational aspects where they did their training, fellowship, that's also important. But most importantly is obviously the surgical talent and where they practice and how safe it is and the outcomes.
Yeah, I would echo what Roger said. You can definitely, we all know in academics people who are outstanding at publishing papers, but not necessarily the kind of people that you might want operating on you. But at the same time, most people in academics are going to be, on average, significantly better than the average spine surgeon out there. They say if you want something done, give it to somebody who's very busy, because they're able to juggle many things at once. And if you're in academics, you're writing papers, you're doing research, you're teaching, and then you're working as a doctor also, like all the other doctors that are in private practice. So you have to be able to juggle all of those things and get them all done. And the other benefit of being in academics is that you have a lot of people looking over your shoulders. We have conferences where we discuss cases, we talk to each other, we collaborate. When we have a question, we can go to somebody who's a world expert in something and say, what would you do about this? And then you can get multiple opinions. You certainly can do that in private practice, but it's a lot more difficult to do that. And the people you're practicing with may not be at the forefront of research in that particular field. So there are definite advantages of seeking out care in a major academic center, and that's in virtually any city. And then I would echo what Roger also said about having a collaborative relationship between all the different subspecialties. We were just on another webinar from 4 to 5, where we had physiatrists, pain management doctors, neurosurgeons, neurologists, psychiatrists, and orthopedic surgeons. And we were all discussing cases, difficult cases that we were talking about, and saying, could this be hypothyroidism instead of a spine problem? And that's the wonderful thing about being in an environment like what we have at Cornell, is that we have a multidisciplinary approach. We have conferences, we teach each other, and we share each other's perspectives on any given problem. And that's what you get when you go and see a doctor at an academic institution like ours. You end up getting the opinions of multiple people, and when you go and see them and they tell you, this is what I would recommend for surgery, well, they're being looked over by fellows, residents, their partners, other spine surgeons, and so you're getting a lot of feedback that's separate from just getting other opinions from other surgeons yourself. That doesn't necessarily happen if you're in solo practice. If you're by yourself, it's, nobody's looking over your shoulders to make sure that what you're doing makes sense, that it's reasonable, that if you have a complication, that you discuss that complication, and you can rely on other people's opinions and thoughts on how to handle all of that. So I think those are some of the significant benefits we have when we have a multiple ways of approaching things and a multidisciplinary approach to managing spine care. Because spine is definitely one of the most complex parts of the body. And there's so many things that can go wrong with spine surgery. People ask me when they come in and they say, I'm very nervous about having my neck operated on. And I said, if you're not nervous about having your cervical spine operated on, there's something seriously wrong with you, because a lot of bad things can happen. You could become a quadriplegic, you could die, you could have injuries to structures in your neck. But the good news is that's like saying that if you fly in an airplane, you could fall out of the sky. In the vast majority of the cases, nothing bad happens. If you get on a commercial airplane, your chances of dying is about 1 in 2 million. And in capable, qualified hands, your chances of dying through cervical spine surgery is almost zero. Your chances of becoming quadriplegic is almost zero. And infection rates are extremely low. And so it's a matter of understanding that, yes, while there are risks, you have to look at it in perspective and understand that those risks can be managed by having a qualified surgeon who's highly experienced at what they do. You look at somebody like, Roger, who is world renowned as a minimally invasive spine surgeon, and he teaches people from all over the world. We've taught courses in many different countries. He goes to Africa to operate, and he is. People come from all over the world to learn from him. And that if other surgeons come to learn from him, other surgeons get their care from him, and other surgeons ask him to teach courses, so that he's at the very top of his game. That I think that's probably the best endorsement you can get as a surgeon, is if you have surgeons who are your patients, doctors who are your patients, other spine surgeons who want you to operate on them, because they're the only ones that can really that are really qualified to judge what you're doing. I liken it to saying that I see in Olympics people diving into a pool, and the judges say that's a 9.2, that's an 8.7, and I can't tell the difference. They have to slow it down to very ultra slow motion. They say, well, the foot wasn't pointed just right. There was a little extra splash, so you get -3 points. But those judges, they do that. They know they can see it in an instant without the instant replay in slow motion. It's the same thing. A spine surgeon can look at another spine surgeon in 5 minutes, know whether that person is good or not. You can hear them at a conference and know whether they make sense or not. And so that's one of the other ways, I think, that I forgot to say earlier, that you can find out if a spine surgeon operates on a lot of spine surgeons. It's a reasonable bet that that's a competent person.
Well, let's address that, and let's do some rapid fire questions that are coming in. One question that came about was, how does a patient learn about the outcome of a surgeon's previous operations? How do they know that they've been operating on other surgeons? Roger, I'll give you that one.
Yeah, I mean, that's difficult, because there's no registry, and there's no way to publish that. That's not being tracked. But there are indirect, they're indicators. You can ask, first of all, you can ask that question, how many of, do you operate on other surgeons as a patient? I think it's not a totally unreasonable question. It may actually allow the surgeon to kind of expand a little bit more, and maybe it's actually a good question. There are other indicators that I encourage patients to use to figure out if a surgeon really is also available for them. Do they give you their contact information, their email? Does the office respond? If they're not responsive before surgery, there's a good chance they're not going to be responsive after surgery either. So that's a good indicator. The other question is second opinions. If you see a surgeon and you get the sense that they don't really encourage you getting a second opinion, that could be a little bit of a red flag. And so there are like indirect things that you can look at as a patient to figure out, which surgeon is really open and which surgeon kind of has a good conscience and really has a good reputation. So those are, obviously the outcomes. That's for cardiac surgery. Some of the outcomes I think are listed online. In spine surgery, we don't have that, or the mortality rates are listed for certain types of surgeries. I don't know, Neil. Any other? I don't know. How do you guys pick when you have patients? How do you pick?
I mean, we actually, besides the relationships that we develop with the surgeons, I mean, we trust what our patients say as well. And if we see great things coming from our patients, which we're very fortunate and lucky to have here in our center, that we have such great experiences, we tend to, use those experiences to share with other patients. And we give some concrete feedback.
I see another question here, which is interesting. Spondylolisthesis, is that a neurological or orthopedic problem? What I'm thinking when I see that question is that, it is difficult for patients to make that distinction. It doesn't really matter for spine these days. The important thing is that surgeon fellowship trained in spine? Do they have had specialty training in spinal surgery? So we don't really think about certain spinal pathologies anymore in terms of neurological or orthopedic. An exception maybe spinal tumor. Those are, for the most part, are still neurosurgical problems. And then maybe very, very complex deformity surgery. For complex deformity is probably more likely to be an orthopedic spine surgeon. But for 90% of what we do in spine, it's really either neurological or orthopedic. The important thing is that person is specialty, fellowship trained in spinal surgery. And that's something that every patient can obviously check upon.
Yeah, I would agree with that. So we have a fellowship where we train 4 fellows a year. And of the 4 fellows, this year it happens to be 3 neurosurgeon and 3 neurosurgeons and 1 orthopedic surgeon. Next year it'll be, I think, 2 and 2. Sometimes it's 3 orthopedic surgeons and 1 neurosurgeon. And we don't teach the neurosurgeons something different from the orthopedic surgeons. We teach them the exact same way of doing things. And when somebody asks me, who should I go and see in Los Angeles or in Chicago or in Asheville, North Carolina, I tell them who the best person is there. I don't say this person is a neurosurgeon, this person is an orthopedic surgeon, because now we have so many joint conferences and we share so much in common that it's not the specialty, it's the individual. It's like saying, which car should I buy, a GM or a Ford? And I say, well, there are great GMs and terrible GM cars, and there are great Fords and bad Fords. So I would point you to a specific person as opposed to what their specialty interests are. And and I would agree with Roger, if you have an intradural tumor, something that's inside of the sac that holds the spinal cord, 99.9% of that in the United States is handled by neurosurgeons. Everything outside of that, I would say, is handled by both neuro and orthopedic surgeons. I mean, even complex deformities. One of my partners, Larry Link, he does tremendous complex deformities, and he doesn't say to the neurosurgery fellows, I'm not going to teach you that. He teaches them exactly the same way as he teaches the orthopedic fellows. So I think the only difference at this point is intradural tumors. If you have a tumor within the substance of the spinal cord or within the sac, in the United States still, I would say that's 99% neurosurgical territory. And I think it'll probably always stay that way. But there are a lot of us in the spine field that want to see spine as its own specialty. I've been advocating for that for a long, long time, because spine is a very complex field. And rather than training just in orthopedic surgery or neurosurgery, I think it's wonderful to have a combination of neurosurgeons and orthopedic surgeons. And I've spoken about this topic in front of the American Academy of Neurological Surgeons and in front of North American Spine Society and many other societies. And there are a lot of people who agree with me, actually.
And
We certainly see that in the pain management world as well, where there's multiple disciplines coming and overlapping and grow together. I wanted to know a couple of things. One is we've talked a few times about second opinions and from potentially faraway places. What's the process for second opinion with you guys? How does one get it? And then also, how do you approach it?
Yeah, I mean, the second opinion now is very easy because we do telemedicine. As you know, we've really switched. About 30% of what we do now is really telemedicine. And initially it was kind of forced upon us because of COVID. But I think now all of us agree that it actually expands our opportunities and our ability to provide second, third opinions for patients who are not necessarily in the city or, worried about coming to the spine center, which actually shouldn't be a worry because it's very, very safe. Same is true with the hospital. But there are certain advantages. You can, especially if you don't live in the city, and the website that you mentioned, we can be contacted via the website, via our individual telephone numbers, and I give a lot of, and Dan does as well, and Neil, you also international patients. It's by WhatsApp or by Zoom, via Epic. It's I think it's an incredibly helpful tool that we have now available to provide better care, evaluation care, and then also follow up after surgery to our patients.
What particular tests would you want ahead of time, Dan, for someone seeking a second opinion from you?
Well, everybody who sees me needs to have had an MRI scan, and the reason for that is that I can make much more valuable use of their time if I can tell them what's going on. If they come and they say, I haven't had any kind of workup, I don't know what's wrong. By telehealth, it's almost impossible to know what's going on with them and to give them any meaningful advice. And also, you have to understand that a spine surgeon is sort of the last person you want to see when you have a neck problem. You want to see the pain management doctor like you. You want to see a neurologist. You want to see a physiatrist. And you want to go through all the non-operative treatment first, and then think of surgery as an option of last resort. So, the vast majority of my patients that I see are patients who've had extensive treatment that have lasted sometimes even a decade or more. And it is much easier for patients to come and see us now through telehealth. I don't know what's going to happen because right now insurance allows for all of that, but I've heard some rumblings about that they won't do that once COVID is over. But it's certainly been wonderful for patients because I saw a woman last night at 6:30 p.m. So I came home, I had office hours, and then I had a meeting, and then I got home. And then from 6:30 until 7:45, I spent a long time with her because she was from Arizona, and she had surgery out there by two different surgeons, and she had seen somebody by telehealth in Indianapolis, Indiana. She had seen somebody, another doctor from New York, a doctor from Los Angeles, and I was the fifth surgeon that was consulting on her problem. And so it was wonderful for her because she could get 5 different opinions without leaving the comfort of her home and just holding up her iPhone. And I thought, this is the amazing thing about all the technology that we're using, that people can do that. I saw a person from, as I said, Arizona, North Carolina, Florida, and there was one other state. I had 4 telehealth visits, and none of them were from New York because the New York patients could just come in and see us in person. But that telehealth allows for getting a second opinion and a third and a fourth and a fifth opinion. And then one other thing that you should do when you talk to other surgeons is say, listen, I have seen this doctor, this doctor, this doctor. What do you think about their reputations? And what do you think about them as people? Would you go to them? And if, every other surgeon that you talk to said, oh boy, that person, I wouldn't send my worst enemy to that doctor. And you hear that from every person you talk to, they're probably right that you probably shouldn't go and see that person. But if the other people say, yeah, he's a good guy, you're in good hands with that person, that should tell you that you found a reasonable person. And so when you go and get other opinions, I think it's a very reasonable question to ask. What Roger said earlier: how many doctors do you operate on? How many doctors? Would you have any doctor patients that would be willing to talk to me to tell me what they really think about you, and and then ask other second and third and fourth opinions what they think about your reputation. And so that's one way that you can sort of get at the kind of information that we in the field have easy access to.
So if I can,
That said, though, let me just say,
Yeah.
with a second opinion, because on the other hand, what we see now frequently is that patients really get, maybe exaggerate. They get like 5, 6, 7 different opinions. And what I've seen in my practice is patients get totally confused
right,
because, and that's the special thing about spine. You talk to 5 spine surgeons, you get 10 different opinions. And why is that? Well, because it's a very complicated field. So at some point, I think it's helpful to get a number of different opinions. However, at some point, you got to look at all these other things that are listed here on the slide, maybe, and you got to make a decision. At some point, you got to make a decision. And
yeah, and that's an excellent point, Roger, because this lady had gotten several different opinions, and they all said different things.
yeah,
And so I said, listen, it sounds different, but at the end of the day, you saw Rick Sasso, who's a friend of mine in Indianapolis. He's an excellent surgeon. He's a good friend of mine. He's excellent. I would send my family members to Rick Sasso in Indianapolis. You saw Jeff Wong in Los Angeles. He's a good friend of mine. I would send my family members to Jeff Wong. You saw Young Kim in New York. I would send my family members to him. You saw Juan Uribe at the Barrows Neurologic Institute he's a good friend of mine. He's an excellent surgeon. There's no reason for you to come all the way to New York to have this done when you've got good people in Arizona. I can give you the names of 2 of my fellows, both at Mayo Clinic in Arizona, that are excellent surgeons that you can go and see. So I can make recommendations and say, these are the people that you should go and see. And she said, but I'm so confused because I've gotten so many different opinions. I said, listen, if you hire 5 architects and you ask them to draw plans of building you a house, they're going to come up with 5 totally different plans. But odds are, no matter which one you choose, if you like that architect, you go over the thought process, you plan it together, you're going to be very happy in the house that architect builds you. And it's the exact same thing. There are many ways to treat a spinal problem. You can do it from the front, you can do it from the back, you can do it from the front and the back. Each one has its pluses and minuses. But at the end of the day, you're likely to be happy if you chose a good surgeon who's got a lot of common sense, who can talk to you, who can relate to you, and who you can relate to, who's got a good bedside manner, who cares about you as a human being and not just as a patient-doctor relationship, but to think of you as somebody that they would care for the way that they would care for their family members. Then I think that you will be happy regardless of what happens. You'll trust that person. And trust is so, so very important, because a lot of what we do, when I teach fellows, I say, you got to understand that in the olden days, before doctors had all these fancy tools, about all they could do was they could come talk to you, lay their hands on you, and there was a magic healing touch. And I remember when I was a teenager, and when I was in my 8, 9, 10 years old, I would go see my general practitioner. And every time I would go see this doctor, Dr. Pollack, he would palpate my neck. What he's feeling for are lymph nodes to make sure that I didn't have lymphoma or anything. I had no idea what he was doing because I'm like 8 years old. But just doing that made me feel so good. And no matter what problem I had, I would go ahead to him, he would do this, he would examine me, and I would leave the office sort of kind of feeling kind of euphoric. And that's the magic power of touch that doctors have. And that if you trust your doctor, if you like your doctor, and your doctor likes you, you have a special bond. And that helps you get over a problem much better than if you hate your doctor. That's why bedside manners are very important, because they say 20% of what we do is a placebo effect. And I totally believe it. If you're not using that 20%, you're 20% less of a surgeon than somebody who actually uses that. And that's why it's very important to put the person at ease, because everybody's scared. Nobody wants to have spine surgery. And if you're not, as I said, scared about having spine surgery, there's something seriously wrong with you. So people are scared to death, and you got to have the ability to put them at ease and to make them feel that, you know what, I'm in good hands. I'm not going to get a terrible complication. This person has done this thousands of times, and it comes out well, time after time after time. And again, you don't just have to ask doctors. Ask them if you could talk to a patient of theirs and see, what is this person like before surgery, the day after the surgery, 1 month after the surgery, a year after the surgery? Would you recommend this doctor to a family member? Now, every doctor has people who love them and people who hate them. Everybody does. I hate to say it, everybody does. So you have to understand that you have to get a wide-ranging set of opinions. And now, I mean, there are a lot of things. I mean, you see patients who put out there on the web what they think about a patient, and they'll say some very honest things. Either I hated this person because of X, Y, Z, or I love this person because of X, Y, Z. So that's another thing. I mean, it's not, again, that's just a part of what you should look at. So you should look at all of that kind of stuff when you pick your doctor.
So we're in our last few minutes. Thank you for sharing that. And a lot of the questions hit on that and how you choose and how do you determine bedside manners and so forth. I thought it'd be great to close with sort of a sense of what led you to this specialty and how did you shape your practice the way that you have? I mean, both of you have kind of honed in on a particular type of spine surgery. So, Roger, if we start with you and
Sure.
how you got to where you are.
No, that's a great question. And I just talked about that at a different meeting the other day. When I trained as a neurosurgeon here at Cornell, first in Pittsburgh and then here in Cornell. I love brain surgery. As a matter of fact, I love microsurgical, the microsurgical aspects, operating under the microscope on the brain tumor. And I really enjoyed that. And then as I kind of grew during my residency, I became more comfortable. I learned more about spine. I realized that, spine was actually really interesting. It was involved. There was a lot of physical work involved with spine surgery, because you would make big incisions, open the muscle, and I was wondering if there was a way to maybe translate what I learned as a neurosurgeon with brain surgery into the spine world, because I always figured there's no real reason why spine surgery has to be so mechanical and so so physically involved. And then initially I was worried because I thought, well, now I'm really working under the microscope. I use navigation. I use all these technical gadgets in brain surgery. If I go into spine surgery, I'm never going to use that anymore. So it was a little bit of a challenge, and but I took it on, and I really loved working on the spine, and I loved it then because I had the opportunity to kind of translate what I had learned as a neurosurgeon into the spine world. And I know Dan uses the microscope a lot, but a lot of spine surgeons in those days, it's not that long ago, but a lot of spine surgeons didn't use the microscope. They would do everything with loupes or even without magnification. So for me, it was very exciting to kind of use what I've, started using what I was trained as in brain surgery in the spine world. And then also now with navigation and augmented reality and virtual reality, that all these technologies that are coming out and that we're working on, and spine is just a widely open field for development and for innovation. And then that was the technical aspect. And the other aspect then was when I realized that we don't really work with other subspecialties, that we, as surgeons, we really, 5% of what patients need is surgery. 95% is really all the other stuff. We need a better diagnosis, non-operative treatment, maybe injections, mindfulness, cognitive behavioral therapy. All these things have to come together. So that was then more on a clinical perspective. The other component that really attracted me to spine, it was like the Wild West, and I think we're kind of now in the phase where we're bringing civilization into the Wild West, better technology, better way to address spinal issues, comprehensive treatment. So for me, it was just a big challenge, and it's really exciting to be part of it now and to see how slowly everything comes together, in my opinion.
And Dan, you specialize in cervical spine. How did you come about to that?
So I trained with a man named Henry Bowman, who was considered in the orthopedic world the top cervical spine surgeon in the world. And after doing a fellowship with him, I was hired by Washington University in St. Louis, specifically because I had trained with him. And when I first started at Washington University, they decided to send out a bunch of cards to referring doctors. And on that card, it said Dan Rue, cervical spine surgery. And I said, that's a big mistake because there's nobody in the world that just does cervical spine. Even my mentor, Dr. Bowman, had a practice that was only 45% cervical spine. And I said, I'm going to starve to death because cervical spine only comprises about 25% of all spinal problems. So it's like saying that I'm not even a spine surgeon. I'm just a cervical spine surgeon. You just can't make a living doing that. And they say, well, I'm sorry, we've just blown all of our marketing. They don't have a lot of money for marketing in the academic world. And so they said that postcard was it. And you're just going to have to make do with it. So fortunately, I had partners who were world renowned at what they were doing. And patients figured, hey, if I tag along with them, I couldn't be half bad if I was one of their partners. And so people started coming in, and one thing led to another. And from the outset, I was about 75% cervical and 25% thoracolumbar. But as I started doing it, I realized that I really enjoyed cervical a lot. It was complex. It was, in a sense, is more dangerous in the sense that if you slip up in the cervical spine, the patient either dies or becomes quadriplegic. And so that, I think, drew me to it, because the ability to say, I'm never going to render anyone a quadriplegic. And knock on wood, it's been 6,000 cases and it's never happened to me. And so that is the excitement part of the operation. And I enjoyed that. And I enjoyed the fact that cervical spine patients tend to do much better. If you ask the average spine surgeon, who do you think does better, lumbar patients or cervical patients? It's unanimous. They'll say cervical patients.
Roger, do you agree with that?
But then
By nature of the problem, he's probably right.
Right. It's because the cervical spine, it's not under the kind of loads that lumbar spine is under. And so I said, I want to be in a field where the patients are going to do well most of the time. And so I enjoyed that. And then as I did it, I think what happens is if you only specialize in a small area, that people just assume that you must know a few tricks and tips. And so the practice kept on growing, and one thing led to another, and ended up after about 5 years saying, I only do cervical spine. I won't do any thoracolumbar cases. And now it's been over 3 years that I've just done exclusively cervical spine. There was a neurosurgeon by named Ron Affelbaum, who was a friend of mine at the University of Utah. He was a cervical only spine surgeon in the United States. And we would say we should start the cervical only spine surgeons organization in the United States, because we're the only two people that only do cervical spine in the US. There's a friend in China at the Third Hospital of Beijing University who does only cervical spine. I do. And then there's one or two people in Europe that just do cervical spine, but there are only about 4 or 5 of us in the world that just do cervical spine. It's just, I've always enjoyed it, and the folks that do also enjoy it. I see here some questions in the chat. Are we going to get to those things?
We've been doing them. We've been going through them. So, we don't always get a chance to do all of them, but we're coming to an end. Last couple minutes. Tell me what, the theme today is really getting to know your surgeon and understanding who they are. Tell me what you guys do for fun.
Neil, I'll tell you in a second. Because of gender diversity and that being such a huge issue, I just want to say 2 sentences.
Sure.
About
it's a great question that came up there.
So because we just looked at that, about 12% of neurosurgeons are women right now. Only about 2 to 3% of orthopedic spine surgeons are women. So there's a clear issue, there's a clear problem. And we're trying to address that within Columbia and Cornell. We're actually merging the spine programs between Columbia and Cornell under Ox Spine. And we haven't mentioned that here today. And we're not going to go into it any further now, but I just want to mention that. And one of the goals is really to put special attention on hiring female spine surgeons. Our neurosurgery residents this year are both female that we hired just a few weeks ago, and we're going to do the same thing within spine. And that's definitely an emphasis. And there are excellent, female spine surgeons out there, even in New York, and we totally realize the importance of the subject. In terms of fun, everybody who's been to the spine center has seen the pictures. Skiing, climbing, hiking. That's my outlet. Dan, what do you do?
So my most favorite activity is spending time with my wife, and we go hiking almost
she must
every
be in the room.
almost every single weekend. We go hiking, and so we go hiking around Bear Mountain here. But we've hiked in New Zealand, in Switzerland, in Africa, and in Asia, and we've got some interesting hikes planned. But I've skied with Roger. I can tell you, he's a world-class skier. He almost got me killed because I tried to keep up with him one time in Whistler when we were at a meeting together. But he's a phenomenal skier, and all the other guys said, "Oh, never to follow Roger because he's too good."
Well, great. Well, gentlemen, thank you for spending your time with us and sharing a little bit about the differences and really the similarities between orthopedic and neurosurgery in terms of approach to spine. I again want to share that our past webinars are found at spine-time.org. And in 2 weeks, we have a upcoming talk from another neurosurgeon, Dr. Kai-Ming Fu, regarding will your back be ready when the pandemic has passed? That will be April 21st. And then the next Spine Time session is going to be a fun one on May 5th, Wine and Spine, talking about some of the things that we're doing for fun to be involved in spine care. So again, thank you for your time and tuning in. We welcome your questions and certainly make appointments if you'd like to do so, and have a good evening.
Thank you, everyone. Thanks, Neil. Great job.
Yeah, great. Awesome.
Yeah.